Welcome back to The Short Code, coming to you from the amazing and intense world of med school. From the University of Iowa Carver College of Medicine, I'm Dave Etler, and on this episode, we're talking about rural medicine. Rural medicine and the folks who want to someday practice it. Why? Where? Doing what? How? I don't know. That's why we have med students for co-hosts on the show, like M2 Megan Perry.
Hello.
M2 Cassidy Brady is here.
Hey.
M2 Shrishti Mather is here.
Hello.
And M1 Megan Amon. Amon?
Yep.
Okay.
Howie.
I always have to check, and I'm always wrong. So just a few stats to get us oriented. The National Rural Health Alliance tells me on their website, rural Americans lack access to healthcare relative to urban Americans. The number of docs per 10,000 people in rural areas is 13.1 versus 31.2 for urban areas. And the number of specialists per 10,000 is 3 in rural America versus 26.3 for urban areas. Meanwhile, rural Americans are at 22% greater risk of injury-related death. They are more frequently diabetic and have more coronary artery disease. The barriers to care are greater. Just thinking of things like distance one has to travel to see a doc or go to the hospital. So there's a clear need for rural physicians. And you guys wanted to talk about your plans, hopefully to do rural medicine.
Yeah. I mean, I think upbringing probably has a lot to do with motivation for probably a lot of us being like from smaller towns and seeing a lot of that need like firsthand growing up, I think has been like a big influence, at least for me. I'm from Gardnerville, Nevada.
Okay.
It's a small town about like an hour south of Reno, Nevada. So it's northern Nevada.
Okay.
Yeah. What about everybody else?
I'm from LaSalle, Illinois, which is like 2 hours east of Iowa City.
Yeah, if you've driven that stretch from Chicago to Iowa City, you've
probably seen the sign.
You've seen the nothing.
Yes.
That is out there. And that's, you know what, that's annoying of me to say. I'm sorry.
Oh, no.
It's probably so much. It's a rich tapestry of existence.
Hidden gems.
Yeah.
You just have to know them.
Okay.
Yeah, I'm originally from Epworth, Iowa, which is about 30 minutes west of like Dubuque, kind of by the Mississippi. I always like to call it like right by like the nose of Iowa on the map. It's like an hour and 15 minutes northeast of here. So yeah, it's also got beautiful scenic drives around this time of the year once you get more close to Dubuque where there's the cliffs and the hills. Otherwise now all the corn's pretty much gone. So it's not as pretty right now.
Not much, yeah.
But when you get to the trees, it's got some beauty.
I am from Ames, Iowa, which is like, it's rural by some calculations, not rural by other calculations. I've talked to people and they said Ames does count, so that's cool for me.
All right.
Additionally, like my whole family, we work in agriculture and agriculture adjacent. And so like even right now, my mom lives in the middle of nowhere, New Hampshire, and are constantly like, that is the demographic that I'm surrounded by of like ag workers and migrant workers. So like that's also part of my drive. Yeah.
How do you think it's influenced your ideas about your career in medicine specifically?
I feel like growing up in a smaller area, you have a very skewed perception of healthcare because for me, all I've ever known is primary care. And so I think that's kind of fueling me wanting to go into primary care also because that's just like what I'm modeling, I guess. I don't know. We don't have many specialists in our area. And like, I guess I'm lucky enough that I've never needed to see one. So it's not been a problem, but I would just go to my pediatrician and my siblings went there and my parents went to the same doctor and it was just very, I don't know. It's just what I've grown up around. So I think it is what I think
the true definition of family practice. I guess.
Yeah, for sure.
Yeah, I think I like the generalizability of primary care. I like the ability to do all types of medicine and I like the ability to work with all types of people like age, background, what they do, and I think family med and rural family med specifically give me that.
Mm-hmm.
Yeah. One thing that I really like about the idea of rural practice is that, you know, we're always discussing how important it is to have that patient-physician connection. Mm-hmm. And by both being from a rural area, you already have that. You know, you have that one thing. So I think it offers the opportunity to open up a lot of doors up front and to create a really strong, trusted relationship. But also, I love the idea about being able to perform like a greater role in the community too. At least for me anyway, going forward. I don't just see myself practicing as a physician in a clinic, but I also see myself as advocating for public health in the community. So kind of like a two-head, wearing two different hats, you know? So, and I like how by being in such a smaller community, you really do have the ability to take on roles like that and truly make some big differences in these smaller communities.
I think you have to wear multiple hats in it if you're a physician in a small community.
Yes,
I don't think it's really an option, really.
Well,
right?
what's funny is because my what I was going to say was kind of similar to what Cass was talking about, where my perception of medicine wasn't like necessarily the same as that kind of thing. I mean, my dad's a doctor, so he worked at our community hospital when I was growing up, and for him it was very typical. He's internal medicine, so he did his hospital days, and then he had his office across from the hospital that he would see patients in until he eventually just moved to only doing hospital. But that's pretty much what he did. He didn't necessarily do a lot of advocacy. He didn't do research. He didn't do anything. And then I come to an academic center for school, and like all these physicians are talking about how they're like, well, I have research days, or I have days where I'm working on public health things. And I'm like, you can do that? I didn't even know you could do that. So I had the similar thing of sometimes I think you maybe do get kind of pigeonholed into being the provider that you're needed there. At least that was my experience watching him do that.
Which makes sense. I mean,
Yeah.
you know. Are you guys in CRISP?
Nope.
No.
Dang.
No.
Interesting. We have this CCOM Rural. What is it? CCOM Rural. CRI. What is it, Audra?
Something scholarship program.
Interest? No.
Rural interest
I think
scholarship.
it's interest.
Is it? I just made that up.
Wait.
I'm not going to lie.
I mean, it's a good, like, it fills it in well.
Integration? No.
Intervention? No. Just coming up with I words.
Oh, okay, this is going to be fun. CCOM Rural Iowa Scholars.
Oh,
Iowa.
Iowa.
Scholars, not scholarship. All right.
Nice.
Points lost here.
Nice.
Yeah. All right. Clearly, we're not in it.
Yeah.
So.
Yeah.
So we have this CCOM Rural Iowa Scholars Program, which is intended to, sort of, it's a small program. I don't think everybody who
No.
Well, obviously
wants to
not.
go into rural
Yeah.
needs to do this. But okay, well, that question sucked.
Well, I
it
mean,
would be
how
a
the
good-
program works,
Huh?
right? How the program works is my understanding is that it like incentivizes people to continue doing rural medicine in the state of Iowa. Like there's a part where I believe like part of your tuition or all of your tuition is paid.
I think it's 100,000.
Okay,
Yeah.
so there's a capped amount if you do your residency in primary care in a rural setting in Iowa.
I think you have to stick. Is it like a 5-year? thing?
Yeah.
Yeah.
Yeah,
And then-
there's
so-
like a handful, like through the state of Iowa too. If you live within a boundary within so many 5 years, there's like a handful of them where they'll like forgive up to like a very large portion of your loans. So
Yeah.
Even back in my town, they have a lot of different programs, and I don't know if it's hospital specific or if it's like a state of Illinois thing or whatever. But basically, if you go back, they'll for like every 1,000 of your loans that you repay, they'll pay the same. They'll like match you. So they have a lot of good incentivizing programs because I think it's just so high demand that they're willing to cover a lot of your education just to get you back in that area. And maybe it's only for 5 years, or maybe I think the idea is that you end up wanting to stay, but whether or not that happens, I don't know.
Yeah. I know Iowa has done a lot to like try and push to have more people stick around. We're increasing the number of Iowa seats that even get into med school, which there's a lot of mixed opinions on.
Yeah.
I mean,
There's a lot of mixed opinions on that.
seems like one of those things that you just got to try and see what happens.
Right.
I don't know.
Right. But like how well is that going to play out for residency? That's
Yeah, we don't.
ultimate.
It's,
Yeah. But yeah, this state has a very high need. My favorite statistic, I say favorite very, very lightly, is that we are ranked 51st or 52nd in OB-GYN care. I love that statistic. How did we even manage that?
There's
impressive.
only 50 states.
So right, we're including like
Yeah,
Wow.
like behind territories.
we're
Yep.
including territories, and we are at the absolute bottom.
There's a clear need here in Iowa. So you guys are M2s.
Some of
You're-
us.
Got one
so
M1.
We've got one M1. We've got 3 M2s. My apologies. You guys are about to go into clinics.
Yeah, we are.
I'm wondering. Oh, stop, Audra. They'll be back.
Audra,
They'll be back.
you can't get rid of us.
Yeah.
Are you keeping an open mind about specializing, or are you just like, nope, this is what I want to do?
I'm keeping an open mind personally just because I have no idea what I want to do. And I kind of go both ways where I see primary care kind of giving me all of it in one, or specializing into something like really specific that I'm really interested in and I just don't know what it is yet. Yeah, so I don't know. But I think that regardless what I end up deciding to specialize in or do with my career, I want to take that back to a low resource area. And so whether that's staying somewhere here in Iowa, which I'm not opposed to, or going back to Nevada where I'm from, I think we have a high need for specialists there too. And so I think there's a lot of flexibility with that. So that keeps me kind of open.
Yeah. I think I would second that, honestly. Again, like I said, growing up knowing one type of doctor, I feel like that's what I see myself doing. So I'm like, I'll go into family medicine and I'll go back to my hometown and I'll become my doctor. Like I'll be the next one up, But then I also think about, there are so many things that I haven't seen and I don't know yet, and I might really love them. And that could be my passion, and I could still take that back and still contribute to my community or a similar one. So yeah, I guess I'm going in open. Like I think that peds hemonc is really interesting. Super different from family medicine, but like it's neat. I mean, kids everywhere get sick. So, I mean, it really is needed everywhere. So I feel like trying to stay open, I think I have an idea, but you don't know what you don't know. So we'll see.
Yeah, I agree with all of that. I think it's always best to go in with an open mind. I did Miko this past summer, which is a program where they put you in a rural place in Iowa for a little bit in the summer. And it's kind of a choose your own adventure. You do whatever you want. Like, so I was shadowing a ton.
Where were you at?
I was in Council Bluffs, which I don't know how that counts as
southeast.
It's like right next to Omaha.
Okay. Oh, southwest. South. Okay, sure.
Yep. West.
Okay,
let's go there.
I'll put a map here.
Thank you.
And I did that, and I got the chance to like shadow in a bunch of things. I was in the OR. I was working full days in a family clinic practice, and I really liked family medicine. I think it's so far the thing I am good at, but I also haven't tried everything.
Yeah.
So like if you asked me to choose right now, I would say family med, but I can't know for sure.
You can answer even as an M1.
Yeah, well, I got some time to think here. But,
The clock is ticking.
Faster than you think.
I was just
so
saying,
weird.
you
I
think
still-
that and it flies.
I still think it's so weird that I don't know,
first semester
like
is almost up.
I know,
Already.
and you have only a limited amount of time to pick the thing that you're going to do for the rest of your life. Whereas the rest of us, we can I don't know.
Well, granted, I've talked to a lot of like residents and attendings, more than I expected, who are like, "Oh yeah, I started this residency and then I switched," or "Oh yeah, I did this and then I did a fellowship."
I
in
mean, there are
something
people
else.
who do it. I don't know how.
That's my
common
worst
it is.
nightmare.
It is my worst nightmare, also, but it's a possibility.
Oh gosh.
You could do it. You could do it.
Let's hope that I just find my one true love.
Yeah, right.
That is what I hope for you. It sounds
Thank
very
you.
awkward to do it the other way.
What do you think, Megan?
Oh,
what are you going to do?
yeah, I was resonating with all your guys' stuff, keeping my mind open to things. Don't really know yet if primary care in particular is going to be my jive. I have a lot of background in infectious diseases and stuff, and hence my interest in like public health and community health. But like you guys were saying, whatever I do end up doing, I specifically want to bring it, like keep it in Iowa. And whether that means bringing it back home to the Dubuque area, maybe kind of staying within Iowa City, but servicing areas like around, that's definitely up there on what I want to do, because very strong family roots here. Same with my fiance, super strong family roots. And to me, as I'm learning through my ethics courses and stuff, trying to figure out what's really important for you, for me, it's that ability to have the connection with family and friends still.
Yeah.
And that is something I'm not willing to give up as I move forward with my career.
Yeah.
Something cool that just kind of triggered my memory. So I also did Miko this summer.
Oh,
Yeah. And I was in Fairfield, Iowa, which is like an hour south. And it was my first time there. The first day I showed up to start like, I don't know, working, shadowing, whatever you want to call it.
Fairfield, the famous location of the Maharishi.
Yes.
oh
college,
yeah.
yeah.
Maharishi University. Yep.
Yeah.
Yep.
What is that?
It's a community that practices transcendental meditation, and it was actually really interesting to like watch the way that their healthcare is different, because a lot of them, they don't want to do colorectal screening, they don't want to do vaccines, certain vaccines. So most of the time they were coming in, they wanted their vitamins checked, they wanted their labs, they kind of just wanted to know where their health was, to know how to like alter the supplements and stuff that they were taking. Very different than what we're used to here, which is very much so like using drugs to cure people. And so it was just, it was a different experience, but it was cool. But what I was like about like the whole family connection, I remember one day, kind of similar to Shristi, I would like bounce around into like different clinics. And so I was in family medicine one day. So a patient came in with her husband. We took care of her. And then the next week I was in the pediatrics clinic, and then I see the kid's name on the chart, and then I walk in, I was like, oh, it's you guys again. And so like, you really are just like taking care of the whole family in places like that. And I think that's so cool because I was there for 4 weeks and I met this family multiple times already. So like the fact that you could build that connection over years is like, I don't know. I just think that would be so gratifying.
The interesting thing to me about what you've said is that, you know, with the population of Fairfield and what they're generally interested in talking about, is that I think in a lot of places you find, from what I've read, that people aren't necessarily buying what traditional
allopathic medicine
is trying to get people to do.
Yeah.
So maybe get a little practice there, a little.
Yeah. Yeah, actually it was like good experience because especially here, like I said, we talk about drugs all the time and like how we're going to use them. But then to like go somewhere where people are like, that's not on their radar. They don't want to hear about it. You're not going to talk about it. Like, how do you flip script and like,
where do you go from there, having been trained as somebody who's like, well, we have this drug for this.
Right. And I feel like we learn how to like lead the patient interview as we do, like we practice with our simulated patients and whatnot. And like, you're kind of in control there. And then all of a sudden you get into the clinic and they're telling you this is not going to happen. So like, I don't know, you just like, you're not really in control of that interview anymore and you don't get to ask the questions. They're going to kind of tell you what they want. And you have to, I don't know, it was just different than what we've learned here, which I think is really beneficial because like, where else are you going to see that, you know? Probably not at an academic center.
Yeah. Do we talk in courses or things like that about how to deal with that situation? Are you trying to convince people like, no, that allopathic medicine is the best way? Are you trying to just go with it? Like, what's the deal?
Inform? Wait, what does Dr. Colleton say?
Something. The point is like, you're not trying to, you don't want to, obviously, you don't, your goal is not to persuade them or like push them into a certain thing. Just the best method is just to inform them in a way that they understand, because like as we go through our medical career, we're learning tons and tons. We're learning a whole new language.
Yeah.
And sometimes it's
the acronyms alone are just,
right. No, what does CRISP stand for? Who knows?
Yeah, we don't know. We gotta look it up.
And it's because I had the same thing when I was in Council Bluffs of like, yeah, like this is the antibiotic you would use for this thing, but like it was a matter of bridging the gap between what I understood and what they understood. And one thing I really liked about family med is because you get that like long-standing relationship. There were people I saw at the beginning of the month who didn't want this treatment for their hypertension or something like that. And I'd see them again at the end of the month. And like I was able to have that long-term thing of we build on, this is why you need it. This is why this is good. Or if you don't want this, these are the lifestyle changes we can make. And like you can have that long-term relationship with them and work on those things together.
Shortcoats, if you have something you want to say about today's show, about something you want to hear about someday, a question you have, go to theshortcoat.com/tell us and send us a message, or comment, like, subscribe. If you're weird enough to watch us on video, you can do that. Otherwise, that's our show. Until next time, I'm Dave Etler saying, don't let the bastards get you down. Say bye, everybody.
Bye. Bye.